السلام عليكم. وياكم دكتور علي الموسوي من مركز النجف لأمراض القلب. هذا الفيديو التصوير راح نشرح how to perform proper TE. دكتورة سحر الوائلي اختصاصية الإيكو والبرفورم the transesophageal إيكو، ويعني هم دكتور مخلد اختصاص التخدير. دكتور مخلد نريد نسألك شنو التايب اوف انستيزيا اللي نعطيها للمريض in order to perform proper TE. طبعا احنا نعطي الزايلوكين سبراي والزايلوكين جل بالبروم. what type of anesthesia؟
عادة هي تكون جرعة من بين المنوم بين المسكن الآلام، جرعة معينة. يعني أنواع التخدير اللي يسموه اللي هو سيديشن، لايت سيديشن نوعا ما، ممكن نروح إلى ديب سيديشن. المهم الديب سيديشن يعني يسموه النوم العميق الأكثر.
طبعا احنا نجري التي مكان يعني بمركز القلب، نجري بالاستشارية، وعادة نستخدم الميدازولام فقط، ويكون البيشنت a little bit awake يعني but sedated. نجري بالإنعاش تمام بمساعدة المخدرين. شنو الأدوية اللي تستخدموها؟ ميدازولام؟
يعني نستعمل الميدازولام ونستعمل الفنتانيل ونستعمل الدواء الجديد هذا الديكسميثازوميدين. طبعا هذا ويك سيديشن هم حلو، اللي هو ديكسميثازوميدين هم يعني الأدوية الحديثة. ونستعمل أيضا مرات بجرعة قليلة من الكيتامين أو البروبوفول. هذين هم نستعمل بس بدوزات قليلة. احنا نحاول ما نستعمل دواء واحد حتى نقلل الأعراض الجانبية، نستعمل أكثر من دواء بدوزات قليلة.
We feel more comfortable in this issue لأنه البيشنت يكون يعني deeply sedated.
طبعا نحتاج بال TE examination بالبروسيجر ال handling of the probe. This is the most important point. The preferable way like this, fingers down near the bottoms of increase and decrease of the degree during a transesophageal echo. Also to control these two bottoms rounded, but these two bottoms preferably to be controlled before introducing the probe inside the mouth of the patient. After that, it's may do injury to the esophagus. So the first bottom for the flexion of the probe, and the second bottom for left and right, up and down. So like this, straight, left, right. We need a slight flexion of the probe before introducing the probe inside the mouth of the patient. This is the first tip. The second tip important, which is the measuring of the tube of transesophageal. Most important thing to see the measures 10, 20, 30, 40 must be in front of the examiner to know how much introduced inside the mouth of the patient. This is the second tip. The third tip, we start to introduce until 20. Then after that, when the patient asks the patient to swallow, we must proceed more forward inside the esophagus till 30. So, preparation of the patient is most important before proceeding in transesophageal echo. The position of the patient must be left-sided position with a slight flexion of the neck, mouthpiece put in with tongue below the mouthpiece for better swallowing of a transesophageal echo probe. We must ask the patient if there is movable teeth to put it out before introducing the probe, especially in the old age patient. The third tip, which is most important, we have lock bottom in the probe of TE. This is the lock bottom. This is never ever be locked, because when we locked it, the probe will be in a flexion position. When introducing the probe inside the mouth of the patient, inside the esophagus, may do a tear to the esophagus when it's in a flexion position like this. We need the flexion just in the beginning of a transesophageal echo exam, when we need the patient to swallow with the convex position of the throat. Now we try to introduce the transesophageal echo probe inside the mouth of the patient. As we said, slight flexion within the normal anatomy of the throat. And the most important, another tip in the transesophageal echo exam, the handling of the probe from this, to be more control to the transesophageal echo probe, so it's not moving like this. For more control at 20 degree. Flexion of the head of the patient is the most important thing, with left lateral position. Now, as we see, we introduce the probe inside the mouth of the patient. This is the proper way for handling of the probe. Calibration in front of me. The other hand on the increase and decrease angle button. Slight manipulation. The view will pass away. So we must control it better. At 0 degree, we see the 4-chamber view.
Mid-esophageal view. This is a mid-esophageal view.
Yes, this is a mid-esophageal view, 0 degree, 4-chamber view. We can increase slightly the degree, slowly. We see now short axis, aortic view. Slight increase with a slight manipulation, opening the left atrial appendage. As we see, there is a mild spontaneous echo contrast.
Actually, the reason to perform TE for this patient is to give her DC shock. She's atrial fibrillation. And this is, as you see, a thrombus in the left atrial appendage, which is a contraindication
For this.
for DC shock. So this is an indication for the patient to exclude the thrombus, which is actually present in the left atrial appendage.
As we see from the echogenicity of the thrombus, it's echogenic, slightly mobile, mass in the tip of the appendage, which mean it's a fresh thrombus, especially with this slight echo contrast.
They have thrombus?
Yes.
Where?
And the appendage.
The base of left atrial appendage.
Yes. We try to take the more important angles in the left atrial appendage examination as we start from 45 degree.
This is a commercial view of the mitral valve, where you see the A2 and P1, P3.
Slight manipulation, slight turning like this to the probe. We open the appendage. Increase the degree slightly more.
This is an aortic view where we see the mitral valve, LVOT, and aortic valve.
Degree to 120, we can view the bicaval view. Superior the SVC and inferior the IVC. And this is the interatrial.
And this is the proper view in order to check for ASD, sinus venosus ASD, PFO, bicaval view. As you see, the most important manipulation is the probe, rotation of the probe.
Yes.
Clockwise and clockwise rotation of the probe, we will change from the bicaval view to LVOT view, where we see the aortic valve, the mitral valve.
Like this. Simple rotation, simple manipulation. And the same degree.
In order to check the tricuspid valve, we can go to 180 or 080. طبعا عندنا مستوى الاورتيك فالف اذا نريد نخفيه ننزل جوا، يعني when you push the probe deep راح يختفي الاورتيك فالف.
Like this.
مستوى الاورتيك فالف هو يعني فينا نطبع انه احنا اعلى واسفل. اذا ندفع جوا يختفي الاورتيك فالف. بس احنا مثلا this is the tricuspid valve. نرجع للمايكرو. How to perform 3D. دائما ال 3D نختار ستراكشر معين ليكون المايترال فالف. اكو هذا ال 4D زوم بريباريشن. راح نختار باي بلين for the mitral valve. ensure انه البوكس اللي region of interest inside the mitral valve input. then we click on mitral valve. راح يطلع لنا المايترال فالف. نقدر نتحكم بالجين سيتنج. هذا احنا نسميه سيرجيكال فيو، اللي هو راح يكون الاورتيك فالف الساعه 12 فوق، المايترال فالف هنا عندنا الانتيريور بوستيريور ليفلت، A1 A2 A3 B1 B2 B3. التسميه من جهه الليفت اتريال ابندج. تمام. هنا بالاي 2 اكو برولابس اوف ذا ليفلتس. هذا is the intraarterial septum والابندج راح تكون تقريبا الساعه 9. We can also take color doppler in 3D.
Also, we can take 4D for the left atrial appendage to see the thrombus in 4D.
We can take the appendage by plane the same way, and we press up to down And this is the appendage in 4D, and this is the thrombus, as you see.
This is you taking like we sitting in the left atrium and looking for the left atrial appendage.
This is the thrombus, and this is the. You can take this view for dimension measurement in order in the future to put left atrial appendage occluder. We should take a 3D image in order to take the proper measurements, the depth and the mouth of the left atrial appendage in order to select the proper size of appendage occluder.
In the setting of the 4D for left atrial appendage measurement, we will proceed for flexi slice at the level of the left circumflex and below a little bit, which is called the landing zone of the occluder and the depth.
This is the
Yes.
circumflex artery. And always the measurement of the left atrial appendage with the level of the circumflex artery.
There are 4 important views and angling for assessing the size of the left atrial appendage before occluder putting, which is at 60-65 degree, at 90-95 degree, at 120 degree, and at 135 degree.
ممكن هاي كذلك يعني نختار نرجع لصورة الابندج ويفريز الايمج.
2D. Frame by frame.
ونختار area of interest.
Look slices دكتور علي.
Circumflex artery.
We can control these 2 planes in the left atrial appendage for preferable dimension. Up, down, left, right, slight rotation.
هذا حتكون المouth of atrial appendage. We can take the minimal and the largest diameter and take the average diameter in order to select the proper size. Also, the type of atrial appendage is a chicken wing type. We have to know 4 types of atrial appendage. This is how to proper size of the left atrial appendage.
The important thing in left atrial appendage assessment, the dimension and the shape of the appendage. What wing shape, cauliflower shape, and also the wing shape we have 2 types, elongated and rounded. This is different in the measurement. At the level of the left circumflex, this is the first dimension, which is called the neck of the appendage. Below it, few millimeters, which is called the landing zone dimension. And the most important thing also, the depth of the left atrial appendage, which is taken from the level of the circumflex to the tip of the left atrial appendage.
Also, this is the comedial ridge. The ridge اللي يفصل بين left atrial appendage and the pulmonary vein. وهذا هو الpulmonary vein لا تشوفون كذا بلوبلر. This is the pulmonary vein, the left upper pulmonary vein, and this is the appendage, and this is the comedial ridge اللي يفصل بين. We can take pulse wave Doppler here to see the waves of the pulmonary veins اللي تكون كلش حلوة واضحة بالtransesophageal echo. This is the S and D. وماكو تقريبا sometimes we see reverse A flow and pulse wave Doppler.
Also, we can take pulse wave Doppler on the left atrial appendage when there is like this hazy flow, echo contrast, decreased. We will notice decreased velocity in the left atrial appendage, as we see here, which is concomitant with the increased coagulability risk when there is a thrombosis in the left atrial appendage.
Left atrial appendage velocity is a parameter that reflects the liability to form a thrombus in the appendage and indication for anticoagulation. And that's why even the patient, when become a sinus rhythm, she needs to continue anticoagulation because of fibrosis of appendage and impaired velocity.
The normal velocity will be 0.4, 0.5. meter per second and above. As we see here, it's just 0.1, almost 0.2.